Okay. Okay, I guess we'll get started. Okay, in the first lecture we talked about initiation, and now we're going to talk about maintenance, delivery, and lactation in that order. Now, we focus on the endocrine component of this. In the initiation, you needed androgens for libido, and estradiol was particularly important for sperm transport. Now, when we move to maintenance of pregnancy, there's always one hormone you should always think about first when you think about maintenance of pregnancy, and that's progesterone. As I mentioned in November, progesterone is a part of a number of compounds known as progestins, and progestin stands for progestation, so they promote pregnancy. And you need progesterone to remain elevated from the time of fertilization to delivery to maintain the pregnancy. If it falls and remains low at any time, you're going to get a spontaneous abortion. Now, this really fairly simple situation is complicated because there's three different sources or control of progesterone during pregnancy. So there's three stages when you look at progesterone's role in maintenance of pregnancy. The first of these is before implantation. The second is basically the first trimester of pregnancy. And the third is the last 2/3 of pregnancy. Now, if we consider pre-implantation, that's this period between fertilization, which is going to occur about day 15 or so of the cycle because it's got to occur within 24 hours of ovulation, and implantation, which occurs about day 22 or 23 of pregnancy. And the obvious source of progesterone in this period is simply progesterone from the normal corpus luteum. So during this period, whether fertilization occurs or not, progesterone is going to go up and be maintained for about 14 days. So basically, this is just progesterone coming from a normal corpus luteum. And as we've already talked about, it has two important functions for pregnancy. One is it stimulates secretions from the endometrium that are important for embryo survival before implantation, and it induces structural changes in the endometrium. And we know that it's critical for pregnancy because if we induce luteolysis prematurely, like I mentioned the morning after pill does, the woman won't become pregnant. So that gets us to implantation, but something important has to happen at implantation, because if nothing happened, progesterone levels would fall, and 2 to 3 days later, the woman would menstruate, and any embryo that had implanted would be sloughed off along with the lining of the endometrium. So the main thing that happens at implantation is a secretion of a new hormone known as human chorionic gonadotropin. Now, chorionic is because it's produced by the chorion, which is the main source of hormones from the placenta, and gonadotropin means that it acts like a gonadotropin. It stimulates the gonads. And actually, at implantation, you see there's a dramatic increase, almost exponential increase in HCG concentrations throughout the first trimester. And the important role of HCG, it's basically structurally very similar to LH. So it has an alpha and beta subunit, like LH, FSH, and TH. With the alpha units, exactly the same subunit. And the beta subunit is basically like LH with a few extra amino acids added. And its primary role here is to act as a luteotropin. Remember I said LH is a luteotropin during the normal cycle. So it binds to LH receptors on the corpus luteum and maintains the corpus luteum. So it basically prevents luteolysis, and by preventing luteolysis, it prevents menstruation and allows the pregnancy to continue. So during this period, the way to think about it is you need progesterone from the corpus luteum and HCG from the placenta for maintenance of pregnancy. Now, HCG has a couple of important clinical applications. One, if you look how dramatically it goes up early in pregnancy, it's unique to pregnancy. It's not normally produced in non-pregnant women. Levels get very high very quickly, and it's small enough that some of it gets into the urine. So it's an ideal pregnancy test. So if you go to Kroger's or wherever and pick up one of those pregnancy tests, basically it's an immune assay for HCG. And if it's positive, there's a 90% chance that you're pregnant because, as I said, HCG can be made by some cancerous tissues, but it's not made by any normal tissues in the body. So that's one clinical test. The other is it's commonly used as a substitute for LH. Until the advent of molecular biology, it was the only source of hormone that could substitute for LH. And because it appears in the urine, there's hardly any other proteins in the urine. So pharmaceutical companies used to collect the urine from pregnant women early in pregnancy, and it was an ideal source to purify HCG for clinical use. It's still being used now because of the few different amino acids. It has a much longer half-life than LH, so it sticks around for a longer period. And so in some senses, it's more effective in stimulating the gonads. And I might add that it's used in men as well as women because LH has important roles in men. So occasionally you hear about athletes, male athletes who are being teased because they're taking a female hormone, and they're taking HCG probably because they've been taking androgens and the normal androgen levels have gone down. Okay, so that gets us through the first trimester. What about the last, second, and third trimester? That's basically this period, and you'll see that this is about week 12 or so of pregnancy. And you see during this period, HCG is falling dramatically. It hangs around for the rest of pregnancy, but it's probably not doing anything important. I should mention one other thing about HCG, it's some clinical significance, is a lot of people think this dramatic increase in HCG early in pregnancy is one of the primary causes of morning sickness during early pregnancy. That hasn't really been completely tested because it's hard to test. It's hard to convince a woman to be injected with a high dose of HCG to see if she gets morning sick. So, and there aren't any real animal models for it. But during this period, for the last two trimesters, you see progesterone is getting extremely high. This is the progesterone from the luteal phase. So during the first trimester, it's maybe 4 times as higher, but as pregnancy progresses, it gets extremely high. And it turns out this progesterone during this period is coming from the placenta itself. So we think the placenta is actually making progesterone throughout all this period, but it's just not able to make enough to maintain pregnancy. That's why you need the corpus luteum during the first trimester. But in the second and third trimesters, you don't actually need, the woman doesn't need her ovary any longer to maintain pregnancy because the placenta is producing enough progesterone. Now, the primary role of progesterone during this period is to inhibit uterine myometrial contractions. Because if you get some uterine contractions, as we'll talk about, that could trigger some processes that would potentially lead to spontaneous abortions if they're maintained long enough. So that's the primary role in terms of maintenance of pregnancy. These very high levels of progesterone have a couple of important actions. One is they further increase the viscosity of cervical mucus. So during pregnancy, you get what's known as the cervical plug formed, and this helps prevent bacteria from getting up into the uterus and maybe infecting the growing fetus. It has 2 important effects in the mammary gland. It causes further development of the alveoli. Those are the structures in the mammary gland, as we'll talk about a little bit, where milk is produced. But it inhibits milk secretion, so you don't get much milk secretion going on during pregnancy. And finally, it inhibits the immune system. And it's thought that this helps protect the fetus from rejection, because if you think about it, the fetus is in foreign tissue growing in the body of the woman. So you'd think the normal immune system would attack it and kill the fetus. There's probably several different things going on, but one of the things that helps prevent that is probably the high levels of progesterone. Okay, finally, there's 2 other hormones during pregnancy that we need to talk about a little bit. One is estrogen, which also gets extremely high during pregnancy compared to normal levels. And the other is this hormone HCS. If we look at estrogen first, there's a unique thing about estrogen production during pregnancy, and that is it's different from normal estrogen production in non-pregnant women or even in men. And that is it's not estradiol. It's a steroid known as estriol, or E3. Now, the 3 is because it has 3 hydroxyls instead of the 2 for estradiol. And it's basically estradiol with a different hydroxyl produced, another hydroxyl put onto it at the 16 carbon position. Now, it turns out the synthesis of estradiol is similar to the synthesis of estradiol in the ovary in that it involves interactions of two separate tissues. Remember, in the ovary, we had the thecal cells making androgen, and then the granulosa cells converting that androgen to estradiol. Well, the same thing is going on now, but we have different tissues involved. So the fetus is actually making the androgen. In this case, it's the fetal adrenal, not the fetal ovaries. And remember, the primary androgen produced by the adrenal in adults is dehydroepiandrosterone, or DHEA, and it's usually sulfated, so it's more soluble in circulation. So the fetal adrenal makes DHEA sulfate, releases it into the fetal circulation, where it actually travels to the fetal liver, and that's where the 16-hydroxyl is put on the 16 carbon. It then travels to the placenta. The placenta has enzymes that take off the sulfate and convert DHEA into estradiol. But because it already has that extra hydroxyl, the end product is estriol and not estradiol. Now, the high levels of estrogen have two important effects during pregnancy. One, they stimulate growth of the myometrium. And this is important because the myometrium is going to provide the muscle power for delivery, to push the infant out. So you want a nice, strong myometrium when delivery starts. It also has effects on the mammary gland. As estradiol does at puberty, estriol promotes further development of the ducts. Remember, the high levels of progesterone are promoting development of the alveoli. So in combination, you get maximum development of the mammary gland during pregnancy. It also inhibits milk secretion, as was the case for progesterone. Okay, this final hormone, HCS, stands for human chorionic somatomammotropin. That's kind of a weird name, but it's because it has two effects related to two other hormones. Prolactin, that's where the mammotropin comes, and growth hormone, which is sometimes referred to as somatotropin. And there's actually three isoforms. There doesn't seem to be much difference in the biological activity of them. So as its name implies, it has two different hormonal activities. It has a prolactin activity. Now, prolactin is the hormone that normally stimulates milk secretion. Prolactin also has effects to induce the enzymes needed for milk synthesis. So one of the things that's going on in pregnancy is you're inducing all the enzymes needed for milk synthesis, so the mammary gland's ready to go as soon as the infant's born. Turns out this prolactin-like activity is probably not that important for the induction of these enzymes because prolactin secretion from the anterior pituitary goes up very high during pregnancy at the same time. So it's probably the more important of these two. In terms of its growth hormone-like activity, one of the biochemical actions of growth hormone is sort of do the opposite of insulin. So it's going to inhibit glucose uptake in the muscles of the mother. And it's thought that this basically increases blood glucose and is transferring glucose from the mother to the fetus. The fetus needs a lot of energy because it's doing all that growing. So this is thought to be an important physiological action of HCS. Okay, we sort of been focused on endocrinology of what's going on in the mother. One other major system undergoes dramatic changes, several, but this is the one with one of the more dramatic. That's the cardiovascular system. So there's actually a large increase in blood volume during pregnancy, and there's a 20 to 30% increase in blood red cells. So there's a larger increase than in volume than in red blood cells, but there's a dramatic increase overall. And this is important for a couple reasons. The mother now has a new source of blood flow that she didn't have before. She had a low percentage of blood flow going to the uterus when she wasn't pregnant, but now she has a tremendous amount of blood flow going to the fetus to take care of the fetus. So in the absence of any increase in blood flow, she'd be suffering hypotension, severe hypotension throughout the rest of the body. So this helps protect the rest of the body and maintain blood flow to other tissues while maintaining a large amount of blood flow to the fetus. It also is thought to be important because the woman's going to lose some blood during delivery, so it decreases the physiological impact of blood loss during delivery. Now, it's thought to be, in terms of the blood volume, the estriol and progesterone are thought to play an important role in the increase in blood volume by affecting the renin-angiotensin system. So estriol increases the production of angiotensinogen in the liver, and progesterone and estriol increase the amount of renin produced. And together you get a big increase in angiotensin II. That causes a big increase in aldosterone, which is going to increase sodium retention in the mother. And so that's going to increase overall body fluid in the body and increase blood volume. There's also changes going on in hematopoietic hormones that are going to increase the red blood cells. Now, while this is going on, with this big increase in blood volume, normally you think a mother, her blood pressure would go up. That's usually what happens when your blood volume goes up. But blood pressure actually normally decreases, at least during normal pregnancy. And that's because there's a number of things impacting peripheral vascular responsiveness to vascular vasoconstrictors. And so they're much less responsive to normal vasoconstrictors than they normally are. Now, if these compensatory mechanisms aren't activated sufficiently, that can become very dangerous, because you can get a condition known as preeclampsia, which is basically a high blood pressure in the mother. And if it progresses to eclampsia, then that could be fatal for both the mother and the fetus. So it's important for the mother's blood pressure be monitored throughout pregnancy. Finally, talk a little about the fetal adrenal. Fetal adrenal is different from the adult adrenal. It has a section of it known as the fetal zone that only occurs in the developing fetus. And it produces two hormones that are important for the process. One we've already talked about, DHEA sulfate, which is important because it's a precursor for maternal estriol. The other is cortisol. And cortisol goes up later in pregnancy, and it's thought to be a very important hormone to allow the changes in the fetus that ensure that it successfully transitions from life in the womb to life in the real world. There are several targets of this. One is it stimulates lung maturation and surfactant activity, and this allows the lungs to function once the fetus is born. In the heart, it facilitates closure of the ductus arteriosus. This is a vascular connection between the pulmonary artery and the aorta. So normally, in the fetus, the blood flow you don't have half the blood flow, the same blood flow to the lungs as goes to the rest of the body. Most of it gets shunted back to the aorta because the lungs aren't functional at that time. So this closure is essential for the normal lung function, to the blood to pick up oxygen from the lungs. In the liver, it has two important effects. It increases the conversion of T4 to T3, and it increases glycogen storage. And these are important because there's two other functions the mother's been doing for the fetus that the fetus now has to do on its own. One is to maintain body temperature. So the increase of the conversion of T4 to the biologically active form of T3 increases the metabolic rate of the new infant to help maintain body temperature. And the infant's now going to maintain blood glucose by itself. It can't rely on the mother for blood glucose anymore. So it needs some glycogen storage in the liver as a source of glucose during short fasts between nursing. Finally, the increase in cortisol latent in pregnancy may contribute to the initiation of labor. We'll talk about that in a minute. Okay, any questions so far? One other point about the adrenal cortex, the fetal zone actually rapidly regresses after birth, and the definitive zone, this little section right here, develops into an adult adrenal cortex. Doesn't seem very efficient since the fetal zone does the same thing as the adult, but that's the way it happens. Okay, here's a Okay, well, hopefully this isn't too difficult. There's only one of these three hormones that can affect the insulin system. Oops, going to do that over. That's human chorionic somatotropin. Remember I said it does the opposite effects of insulin, so it tends to decrease glucose uptake. So this puts a stress on the mother's pancreas. Normally the pancreas has enough of a reserve that it can produce, basically the mother becomes somewhat insulin resistant during pregnancy. Now if the pancreas is already partially compromised, if the insulin resistance gets too bad, she can actually develop diabetes. Now this goes away after delivery because the source of it, the human chorionic somatotropin, goes away. But there are two important clinical implications for development of gestational diabetes. One is it usually means that the infant at birth is going to be larger than normal because it's getting a lot more energy, and some people think that the insulin may help promote growth. So women who have gestational diabetes tend to have large infants, which can obviously complicate birth. The other important clinical implication, it's an indication that her pancreas is partially compromised already. So she may well develop diabetes, normal diabetes, later in life if she develops gestational diabetes. So that's one reason why women who are getting prenatal care, they always check the the urinary glucose levels to make sure she isn't developing gestational diabetes. Okay, moving on to parturition. We have preparation, initiation, and then labor. Now, parturition, preparation basically involves a softening of the cervix. That's the lower portion of the uterus that the infant's going to have to go through, and a relaxation of the pelvic ligaments. And this appears to be due to a protein hormone produced by the placenta known as relaxin. Now, initiation is one of the unsolved questions in reproductive endocrinology, is what actually triggers labor or parturition in humans. In a lot of species, it's cortisol. It's been well documented that cortisol levels go up from the adrenal cortex, and this actually triggers a cascade of events that leads to uterine contractions and labor. But whereas increasing cortisol may be important in humans, there's other things involved as well. And I think one of the reasons that we haven't really been identified a single trigger is that a variety of factors can trigger it, and so it really depends on what's going on in an individual woman on what the important trigger is. Other important factors that can start on this is fetal size. So the uterine smooth muscle is a smooth muscle. Most smooth muscle responds to stretch by contracting. And there's good evidence that fetal size contributes to the initiation of labor. Mainly it's the women with 2 or 3 fetuses will almost always have early delivery, probably because of fetal size. There's some evidence, although it's a little controversial, that there might be a local decrease in estradiol or decrease in progesterone. Remember, progesterone is a primary factor preventing uterine contractions. One thing we know is there's no systemic changes. So if these changes are important, they have to be local. Finally, more recently, there's some increasing evidence that there's actually a local decrease in response of the uterine myometrium to progesterone. And this involves 2 different types of progesterone receptors. In most tissues where they have these 2 receptors, they're called progesterone receptor A and progesterone receptor B. They have the same effects. But this doesn't seem to be the case in the myometrium. And that's because if progesterone interacts with the B form, that tends to promote gestation, so it tends to inhibit uterine contractions. But for reasons that aren't understood, if it interacts with the A form, it tends to promote uterine myometrium contractions and thus promote labor. And it also tends to block the actions of the B form. Now, it is known now that the A form goes up at the start of labor in women, but the cause of that change isn't really known. Despite this sort of foggy understanding of what triggers labor, we know a lot about what is responsible for maintenance of labor during the actual active contractions. And the primary purpose of labor is simply to dilate the cervix to 10 centimeters. So that's the diameter of the cervix that will allow the fetal head to pass through. And if we look at maintenance of labor, there's an important hormone, oxytocin, from the hypothalamus. And remember, we said early on that oxytocin has two effects. One is to stimulate uterine contractions of the myometrium, and as we'll talk about in a few minutes, it also stimulates smooth muscle contractions in the mammary gland. So what happens once you get labor started is you get contractions of the myometrium smooth muscle, and they actually start at the head and sweep down this way, so that pushes the fetus down onto the cervix. And the pressure on the cervix stretches the cervix, so we have cervical stretch receptors that sense that. They send action potentials up to the neurons in the hypothalamus that produce oxytocin. Oxytocin is released from the posterior pituitary, travels to the circulation, and stimulates further contractions. Now, one thing you'll notice if you look at all these specific steps in the process is they're all positive. So this is one of those rare examples where we have a positive feedback loop, that once this process is initiated, it will continue and actually increase in intensity until delivery of the fetus. Now, once the fetus is delivered, this positive feedback loop is broken because it's broken at this step. You no longer have increase in the stretch receptors, so the whole positive feedback is no longer initiated. Oxytocin levels remain high, so there are continued contraction of the myometrium for some time after delivery of the fetus, and this is important for expulsion of the placenta after delivery. Okay, once you have the infant delivered, you still need to be able to maintain him or her with lactation. And if we look at lactation, it involves a mammary gland. The mammary gland consists of a series of ducts connected to the nipple, and the ducts end in lobules where the milk is produced, and the lobules have a large number of alveoli in them. And getting milk to the infant involves two processes and two cell types. So we have epithelial cells and myoepithelial cells. Now the epithelial cells are where the milk is synthesized and secreted. So secretion is the movement of milk from inside these epithelial cells into the lumen of the alveolus. But we still have to get the milk from this end of the mammary gland to the nipple. And one important aspect of this structure is the infant cannot produce enough negative pressure at the nipple to actually suck the milk out of the alveoli. In part because you have this big branching thing, so any negative pressure dissipates rapidly along this network. But also, if you produce negative pressure, the ductwork tends to collapse. So to overcome that problem, the mammary gland produces positive pressure in the alveoli and lobule, which forces the milk to the nipple and actually increases the diameter of the ductwork. And it does that by causing contractions of myoepithelial cells that decreases the volume of the alveolus and forces the milk out and out through the ductwork to the nipple. Now, if we look at the hormones involved in this, there's 4 of them: estrogen and progesterone. They're critical for structural development of the mammary gland, as we talked about already. And as we mentioned, they inhibit milk secretion during pregnancy. And prolactin is the hormone that stimulates milk synthesis and secretion, whereas oxytocin produces milk ejection. So prolactin is going to work on these epithelial cells because that's where synthesis and secretion occurs, whereas oxytocin is going to work on these myoepithelial cells. So finally, we need a system to get oxytocin. Take this in step again. So first we have preparation, and this is going to be a repeat of what I said in a few other lectures. So at puberty, estradiol and progesterone goes up, so you get the initial development of the mammary glands. Estrogen acts to stimulate growth of the ducts, and progesterone the alveoli. In pregnancy, estradiol and progesterone get very high, It causes final maturation and growth of the mammary gland, but they also inhibit milk secretion. Finally, you get prolactin and human chorionic somatotropin, which induce all the enzymes needed for synthesis. But again, you don't get milk secretion because of the high levels of steroids. So at initiation is not due to prolactin or oxytocin or any of those hormones. It's due to the fact that these high steroids are actively inhibiting milk secretion. So at delivery, the placenta is expelled, so you get a rapid decrease in estradiol and progesterone from the circulation, and that basically removes the inhibitory effects of these steroids on secretion, so that basically initiates the process of milk secretion. So if we look at maintenance, we need mechanisms for stimulating oxytocin and prolactin when needed, and so we have a classic feed-forward system. We mentioned this already as sort of an example of feed-forward systems. So you have the infant suckling at the nipple that causes action potentials up to the hypothalamus, which acts to stimulate oxytocin release. Oxytocin then acts on the smooth muscle myometrium to cause milk ejection, and shortly after suckling starts, the infant can start getting milk as milk's pushed from the alveoli to the nipple. Now, two important aspects of this system because of this key role for the central nervous system. One is it's stress sensitive. So it can be easily inhibited by stress, and this is often important for young mothers with the first time they're trying to nurse a baby, because they're often sort of stressed, or am I going to be able to produce enough milk? And if they're too stressed, then this becomes a self-fulfilling prophecy because they get too stressed, and then this milk ejection reflex doesn't work very well. The other aspect of it can become a conditioned reflex. So after a mother's been nursing for a while, the touch or even the smell of the infant can often trigger oxytocin release, so you actually get some milk let down before the infant starts suckling. Okay, so we've got oxytocin and milk delivered to the infant. We now have to replenish the milk that the infant's been taking from the alveoli, and for that we need prolactin. Prolactin comes from the anterior pituitary, and you remember, so anterior pituitary hormones are controlled by hormones from the hypothalamus that travel from the hypothalamus to the anterior pituitary via the portal system. And prolactin is an unusual one that is controlled primarily by a negative hormone. So its primary control is by dopamine, which inhibits prolactin. So to get prolactin levels up, you have to inhibit dopamine release. So you have these action potentials that are triggered by suckling. They travel to these dopaminergic neurons in the hypothalamus, and they actually inhibit dopamine release. So the net effect of that is that prolactin levels go up. It then acts on the epithelial to increase secretion, and so the alveoli are all ready for milk ejection the next time the infant needs any milk. Okay, a couple of final points about this process. So how are these processes stopped once weaning the infant is weaned? And both the processes by which the lactation is stopped involves both prolactin and oxytocin. And it involves the fact that the feed-forward system is turned off. So we no longer have any signals that increase prolactin or oxytocin. So if there's no prolactin increase, then you're going to decrease secretion because the stimulus for secretion is no longer there. But you still get a little bit going on. It doesn't shut off completely because all those enzymes that have been active for several months are still there. It takes a while for those enzymes to be degraded and secretion to stop completely. So the other factor that helps inhibit lactation is you don't have any oxytocin. So in the presence of continued secretion, even at a low level, without milk ejection, you get a buildup of milk in the alveoli. And this produces increased pressure in the alveoli, and the increased pressure itself tends to inhibit secretion. Finally, just a comment about the potential contraceptive effects of lactation. Now, it's known that in a lot of species, lactation tends to inhibit reproduction. And largely that's because lactation is one of the most energy demanding processes the mother ever has to do. If you think about it, she's producing all the nutrients for an infant that's growing very rapidly. So this produces a tremendous pressure on her energy reserves. And in many cases, individuals are put into situations where they don't have enough energy supplies coming in to maintain normal body function. The first thing to do is shut down reproduction. The idea is you shut down reproduction. You don't need it right now. You don't need it to survive. And so you're going to save energy for other things that are more important for survival than reproductive function. So in a lot of situations, lactation can inhibit reproductive functions. And this is particularly true in the third world, where nutrient levels tend to be low. And also the suckling stimulus tends to be higher because the nutrient's getting all its nutrients from the mother for a longer period of time. Whereas in the Western world, the infant gets to transition to a bottle more rapidly. And of course, women are in much better physical shape. So although lactation can have some contraceptive effects, it's not recommended that a woman rely on that solely to prevent becoming pregnant again. Okay, any questions? If not, thank you.